Well, thank you. So, welcome everyone to another one of Wellspring's Be Well Talks. This is a webinar series that's designed to speak on on a couple different topics on cancer. And again, like we're always looking to talk about new topics, that are things that would appeal to you, things that you're interested in. And so today's talk is on embracing change and navigating breast cancer survivorship for young women. So I'm very excited to present our speakers for today. If I could have the next slide. Perfect. So Dr. Muna Al-Khaifi, if you have attended one of our series before, we did have Dr. Al-Khaifi do a four-part webinar for us last year, I believe it was. So we're very happy to have her back again. So she's currently working as a GP oncologist at Sunnybrook Health Sciences Center. She is the lead of the follow-up and survivorship program at Louis Temetri Breast Cancer Center at Odette Center. She is an assistant professor at the Department of Family and Community Medicine at the University of Toronto and an affiliated scientist at Sunnybrook Research Institute. So her research interests are in breast cancer survivorship, quality of life related research, and sexual and women's health. And so we also have with us today, Sandy, if I could have the next slide. Perfect. So Sandy, who's our slide control master right now, very happy to have her on board today. She is a Canadian certified physician assistant working in breast medical oncology at Sunnybrook Health Sciences Center in Toronto. She's also a patient navigator and program coordinator of the PYNK program for young women with breast cancer. And she spent the first 5 years of her career in surgical gynecologic oncology at Princess Margaret Cancer Center and Juravinsky, where she developed a deep understanding of the intricacies of cancer and its treatment impacts on female patients. And so today we're also very lucky to have a patient speaker with us today, Michelle Lazier, who you will get the chance to meet later on during this presentation. So with that, I'm super excited to have all of these wonderful speakers on board. And Sandy, I will hand it over to you.
Thank you for the introduction, and thank you everyone for joining us today. As per the introduction, I'm a patient navigator in the PYNK program. I also work as a physician assistant in the breast medical oncology program at Sunnybrook. My main role in the PYNK program is to help with navigating resources for patients. So what I'm about to kind of share with you all today are just tidbits of what I share with patients. And of course, if there's any need for more expertise, there will be specialist referral and such. So let me go to the next slide. So just to highlight a bit, after this webinar, I understand our participants are coming from all across Canada. So if you ever want to look at any additional resources, we have a virtual library on our PYNK website that anyone can access. And I've linked the QR code over there. So the goal of today's webinar is to kind of review the complexities of breast cancer survivorship in young women, recognize common challenges faced after breast cancer treatment, and share some practical strategies and resources to how to manage it. My slides are very photo-y and like I don't have a lot of words. I'm just going to be rambling. So I think these challenges exist because life is different in your 20s and 30s. Like this breast cancer diagnosis comes at a time when, for many people may be traveling or trying to get or planning a wedding or starting family. And when cancer comes into the picture, life shifts in ways that can feel disorienting. And when you come out of that experience, going back to routine, regular life, things can feel different because you have that perspective of having experienced a life-threatening illness. Now, some women are fortunate to have support from people who understand and are there every step of the way. Others find themselves feeling isolated when those around them don't know how to support them, or sometimes even say things that aren't helpful, like, you're done with treatment, you'll be fine now. And for many, that couldn't be further from the truth. So, what can you expect after the end of treatment? You can expect to feel different from the person you were before your breast cancer diagnosis. Cancer changes you both physically and psychologically. And for these changes can be positive, sparking motivation to grow or reevaluate what's truly meaningful. Um, and we call this experience post-traumatic growth, recognizing the preciousness of life, ending toxic relationships, finding fulfilling work, and learning to let go of minor worries. And this may not be a universal experience, and it doesn't mean you have to be positive all the time. Two things can be true. You can feel grateful that you came out of this experience, um, um, cancer free, or that your cancer hasn't progressed, or and also grieve what has been lost during that time. At this point in recovery, we find young women often feel an increase in distress. Even though the physically demanding part is over, there's suddenly a lot of time to reflect on what happened. During treatment, there were clear milestones like this is my surgery date, this is the last day of chemo, and there's also constant guidance from the medical team of what needs to be done. And then all of a sudden, at the end of active treatment, you're told, we'll see you in 3 months. And it's easy to feel a bit adrift. How long will it take to recover from cancer treatment? From my experience working with my patients, it can take anywhere from 6 months to a year. So if you're not ready to dive back into work or feel like you're still recovering, that's because you are. The end of treatment is only the beginning of recovery, and we finish doing things to your body and administrating intense medicines to fight the cancer. But recovery is a whole different phase, and this phase can last several months or more. So just starting with one of the common questions I have, or common topics I have in the survivorship or post-active treatment phase is return to work. And in order to return to work successfully, there are several symptoms that needs to be managed well. They don't have to be gone completely, but managed well in order to return to work successfully. Most patients may have been on EI, short-term or long-term disability, and it's difficult to hear, but these payments will run out at some point, and sometimes the payments are not much. And in order to kind of sustain living, they have to return to work, and whether that's returning to a previous job or new job is part of the recovery process. These are some things that my patients have brought up to me. They're worried about their performance. Can I do the work I was doing before? And this is where we have a return to work plan. And it's a gradual process that goes over several weeks. And, it's working with your medical team and your employer on how to successfully integrate you back into work. We never expect you to return to work full time after 6, maybe even 12 months of treatment. Your body needs time to kind of get used to back, to build up that confidence and that stamina again. Um, you would have gotten paperwork from your insurance company or employer for a medical assessment with your medical team. And my tidbit of advice here is just to work with your medical team in terms of describing what you do at work. What do you anticipate will be challenging? What do you anticipate will work well? Because we don't know your job as well as you do. And if you can tell us how we can support you to successfully integrate back into work, then we can be more objective and provide our recommendations on those paperwork. Um, some I have a patient who told me it's like, yeah, after this room, I don't want to go back to my old job. I don't find it meaningful anymore, like whatever I was doing. I want to do something different. And this is great. This is the post-traumatic growth we're talking about. And I think that depending on the individual's financial status, we might suggest returning to the previous job, gain some confidence, and then while having some financial stability, do the job hunt. What am I going to say to my coworkers when they ask me why I was away or how I was doing, etc.? It depends on what feels right to you. There's pros and cons of disclosing how much you want to share, and you might want to practice what you want to say to colleagues. And sometimes you can just redirect their questions like, If they're asking, "Oh, how are you doing? Like, are you feeling better?" etc., you can say, "Thanks for asking. Some days are better than others. How was work here, or how are you when I was gone?" And turn it back to them. Some patients have mentioned, during treatment, especially if they've undergone chemotherapy, have noticed some cognitive changes, such as I'm a bit forgetful. If I don't write things down, I'm going to forget it, or I have to really concentrate hard on what people are saying. So this is all about brain health, and we would we want to prioritize good sleep because that's the medicine for our brain. Good sleep, and physical activity can help with that. Uh, Also adopting memory aids. So yes, maybe in the past you didn't need Google Calendar or your notebook to remind you of what you need to be done. But maybe now it's time to adopt those tools to help you be successful. Um, Last one is fatigue. And it's it's really hard. Fatigue is it's accumulation of all the treatment that you've had. And the gold standard is really physical activity. That's what's been evidence have shown have helped with fatigue. And the more you don't do things, the more tired you're going to feel. So, before going back to work, maybe try living like you're working. Like, what does waking up at 7 o'clock feel like? And, being doing cognitive tasks or doing physical activity, like what does that look like? And then kind of trying to train your body as well to build up for that. Here are some resources that I have pointed patients to before. We have the Wellspring Return to Work program, which I've heard a lot of patients say is really, really good. There's a Princess Margaret short module. It's part of the Adult Cancer Survivorship series, and they have a small tidbit on return to work. And then cancerandwork.ca is a website designed to address the unique needs of cancer survivors with returning to work. So there's a lot of information and resources that you can peruse through. Next, my another topic that patients bring up. Now that I've gone through this, I want to be healthier. I want to change. This is our theme. You're not the same person you were before your breast cancer treatment. So what you did before is not going to work now. You also have to change. Um, so I want to touch upon like menopause in breast cancer treatment. For patients with hormone sensitive breast cancer, more often than not, the adjuvant treatment, so the medication that you take after active treatment will include hormonal therapy, which will induce you into menopause. So you might have been recommended to take a medication called tamoxifen or to receive injections that put your ovaries to sleep. And then in addition, take an aromatase inhibitor such as letrozole or exemestane. And these medications, they might have told you we want you to take for at least a minimum of 5 years, but of course, kind of following up regularly to see how you're tolerating the therapy. For HER2 positive breast cancers or triple negative breast cancers, the hormonal therapy may not be part of the treatment plan, but most patients do get chemotherapy in this setting. And we know that the chemotherapy used in breast cancer treatment can affect the ovaries and decrease the number of eggs and in relation to that the level of estrogen. So some patients may experience early menopause symptoms. Estrogen is good for our health. It protects our heart and blood vessels, strengthens our bones, and prevents cognitive decline. So, in the absence of estrogen, we need to work on optimizing these areas. And while all of these symptoms can impact quality of life, one of the most frustrating symptoms my patients bring up is weight gain. So why is there weight gain in menopause? When we have decrease in estrogen, along with aging in general, this triggers metabolic changes in the body. And one of those changes is that we get decrease in our muscle mass, which means that there are fewer calories being burned. And if there's fewer calories being burned, fat accumulates. The area where the muscle is usually lost is around our midsection. So you might notice that your weight is kind of shifting from your hips and thighs to the midriff area. Um, Genetics, lack of sleep, sedentary lifestyle also play a role. Um, so you can see this vicious cycle where we lose muscle tone, we get more fat as our metabolism is slowing down, and we're going to get more weight gain. And studies have shown that, women with more weight are more likely to report more severe or frequent hot flashes than those with a normal or healthier weight. Um, so these are the recommendations I have. So exercise across the board is the gold standard. And it's a combination of aerobic exercise, so exercises that races your heart, and strength training. And these are some of the benefits. So it lower your risk of cardiovascular disease. It prevents osteoporosis, improves sleep and mood, and kind of combats fatigue and some of those vasomotor or hot flashes, night sweat symptoms. Um, and my recommendation is just start moving, and gradually increase your exercise tolerance. And what the recommendation is 150 minutes of physical activity a week. So that kind of equates to about 30 minutes for over 5 days. And I use this picture because this lady's not running or weightlifting, etc. Because physical activity could just simply just be brisk walking, walking at a pace where you're just a little bit short of breath, or so much short of breath when you're talking. Taking the stairs instead of the elevator. If you enjoy swimming, maybe do that. And maybe this is a time to try new activities. For example, if you've always wanted to try Pilates but was scared, well, here's a chance to try it. If you feel like you need someone to kind of handhold you through, like, what exercises to do and keep yourself accountable, maybe invest in a personal trainer, which is in a way investing in yourself. And once you learn all the techniques and how to do the exercises, then you could do them on your own without a personal trainer. Now we have Wellspring also has a cancer exercise program in Toronto here with on our Sunnybrook campus. We have Westerkirk House, so they do run that program there as well. Some patients tell me, I'm so tired. I'm very exhausted. I can't exercise. I don't have time to do it. You know, I think it's just giving yourself that push, like just do it. Like after that 5 minutes, you're gonna start feeling better because of the endorphins that are naturally released. And whenever we're trying to start a new habit, it takes a good 20 days to set a pattern. So, try to persist for those 20 days, and see where that goes. And again, you know, even just walking for 30 minutes after dinner in your neighborhood counts. Some people say, it's like, yeah, I run after my kids at home. But that won't cut it because, we want your heart to be racing, right? So maybe run after them outside in the park, or join them in in their choice of sports. Um, you know, Sometimes trying to schedule the exercise in your schedule might be hard. So you might have to change the mindset of, like, I'm going to schedule things around my exercise. Um, so that's all I have for exercise here. Okay. Next is, there's physical activity and then there's healthy eating. So prefacing, I'm not a dietitian, and I think it would be beneficial to speak to one if your cancer institution has one. I know Wellspring has dietitian or nutritionist, and also specific programs geared towards eating well and healthy. So I, uh, the physical activity and eating well goes hand in hand. I would say the goal here is to maintain your weight, because we know weight gain is associated with poorer breast cancer outcomes. And the simple formula is calories in, calories out, to maintain weight. And it's easier to not eat your calories than to burn it. So it's weight gain, or sorry, weight maintenance, and weight loss has a lot to do with what you put in yourself. I've had patients say, I've always eaten the same, like I haven't changed, but I keep I keep gaining weight. Well, maybe there is something that needs to be changed. Maybe what worked for you before isn't going to work now. And some kind of general mainstays is, having fruits and vegetables, at least half, kind of half your plate. Choosing whole grains, because whole grains have more fiber. It'll keep you fuller and help with constipation. So examples of whole grains would be like brown rice and oatmeal. And choosing protein-dense food such as chicken, egg, and salmon. I have patients ask me if soy food is safe to eat. It is safe. Tofu, miso, soy milk, that's all okay. The concern is coming out of the safety of soy-based supplements. So those that come in a pill or powder form, that the the safety of that hasn't been determined. And then kind of limit high sodium food and processed food. So what does that look like? So these are some strategies to help with eating better. So meal prepping. So for lunch or for breakfast, you know exactly what you're eating. This helps with cost as well. Adding less salt to your cooking, choosing water as a beverage of choice, and doing simple swaps. Like, you can take a diary of like what you eat every day and see where you can swap out certain things. So, if I tend to grab cookies or crackers for a snack, maybe I'll bring clementine or grapes for a snack instead. Those are easy snacks that you can just put in a container and go. Or, if you're used to eating white rice, maybe swap them for brown rice, breakfast muffins for overnight oats. Um, it yeah, and at the end of the day, you want this to work for you and make it enjoyable. And make it a practice to read food labels, like how much sugar or sodium is in this, how much calorie is in this. And whatever the label this is for, that's a lot of sodium, so you can put that back on the shelf. So for bone health, it's mainly osteoporosis prevention. And I just wanted to highlight here that letrozole, exemestane, Lupron, Zoladex, those medications can thin your bones over time. And zoledronic acid, if you were offered this medication or infusion, it may help protect your bones from some of that effect. And there's also a small benefit in preventing breast cancer from recurring in the bones. Um, you can ask your family doctor for a bone mineral density test as a baseline if you haven't had one already. But in terms of kind of the supplements for good bone health would be vitamin D supplement, calcium through food, and strength-based training. So vitamin D is probably the one that I would say you might want to take a supplement for because there's not a lot of food sources where you can get vitamin D. And going into the winter months, we're not going to get a lot of sun. And calcium is best absorbed, best received in our body through food sources. And lastly, for herbals and supplements, review with your pharmacist. They are like at our center anyway. Our pharmacists are very open to kind of looking over supplements that you're curious about or are taking and seeing if there's any interactions with the current treatment that you're on. And I'm telling you, Wellspring has everything you can try, and you make it a starting point because it's free. And at the Western Kirk House here at Sunnybrook, they also have a kitchen, so sometimes they do classes in person. Um, and I often refer to the Canada's Food Guide for recommendations and some for patients. Next is on growing a family. So the patients I work with come in two groups. One is, they've never had children before and, haven't even thought about it until breast cancer diagnosis came in and they're forced to kind of make certain decisions about fertility preservation. And then I have another group of patients where after breast cancer treatment, like they still want to grow their family. And then a very, very minority were diagnosed in pregnancy. Um, in terms of evidence, we do have studies that support that pregnancy after breast cancer treatment, so after the 5 years of endocrine therapy, does not increase the risk of cancer coming back. While patients are on the endocrine therapy, they should be using contraception as some of these medications can cause birth defects. And when you're ready to get pregnant, then we would want you to stop the medication, give it some time to be cleared out from the body before you start trying. Uh, but not everyone has that luxury of time to wait 5 years to start trying to get pregnant. So there is a group out of Boston, Dana-Farber, who did a study called the Positive Study, looking at is it safe to pause the endocrine therapy for some time to try to get pregnant? Does that increase risk of cancer, breast cancer coming back? Um, so uh, quickly, this slide is just summarizing that, you know, they this is very early data. They've only followed the patients for about 3.5 years. These patients, average age of all the patients that were enrolled were about 37 years old. And the majority of patients, this is important, are stage 1 or stage 2 disease, and only a third of them had positive lymph nodes. So sometimes when you're looking at clinical or studies, you want to see if you fit the patient population in there. Can those results apply to you? So these patients would, they want to get pregnant, so they would stop their endocrine therapy for at least 3 months, and they need to have had taken their endocrine therapy for at least 18 to 30 months. Um, and they have up to 2 years to get pregnant, either naturally or by IVF. And the results show that more than 70% of patients became pregnant, and most had at least one live birth. And what they did, what the investigators did, was that they compared these women with a control group in another study who did not interrupt their therapy and see if there's any significant adverse events. So they did not observe that. So currently, as it stands, there isn't, in the short term anyway, there isn't any increased breast cancer recurrence, but we do need longer term data. And this is definitely something to discuss with your oncologist for shared decision making regarding your personal risk factors. What is your risk of cancer recurrence, like, in terms of like stopping your endocrine therapy treatment or pausing it early? When patients are ready at this phase, in the survivorship phase, when they are ready to pursue pregnancy, I usually recommend patients to see their fertility specialist, because what they can do is they do a blood test and ultrasound and see what your ovaries are doing um, after breast cancer treatment. And then go from there. Because, fertility specialists, like, you can always see them for a consult. They don't always push for IVF. They know it's a lot of work, it's expensive, emotionally draining. And if the family decides, like, no, I want to do the IVF route, Ontario does fund one cycle. And there are onco fertility clinics in Ontario that um, kind of talk to patients about this whole process. If you are a mutation gene carrier, currently there's the technology of pre-implantation genetic testing, which means that when they create the embryos, they can genetically test each embryo to see which one does not have a gene mutation, for example, BRCA, and only implant the ones that are mutation free. This is currently an out-of-pocket cost. And the last note here is, beyond carrying one own's pregnancy or biological child, there are other ways to grow a family that can make sense to you. And there are clinics that can help you with that, or at least share information for you to explore. And sorry, this is my last tidbit on this topic. Any young women with breast cancer contemplating having a baby must be willing to consider the possibility of cancer recurrence while she's caring for an infant, toddler, or young child, and assess whether she has the support for this if this should happen. And we recognize that balancing the risk of cancer recurrence against desire for a baby can be a complex and emotional journey. Last topic for me is living with fear of recurrence or progression. And I would say this is also one of the hardest part of post-treatment phase. And fear of recurrence can be persistent or even heightened, even if the risk of recurrence is low. It's difficult to manage, but maybe we can look at it from different ways of thinking about it and work on behavioral strategies for not reinforcing fears. You have done everything you can to reduce your risk of recurrence, and your oncologists have told you that that risk of recurrence will never be zero, but we want to try to bring it down as close to zero as possible. So we need to find ways of living with that, and instead of getting rid of that fear, we can think about how we can tend to that anxiety, tend to the distress, the worrisome thoughts, and the bodily sensations that to bring the body back to equilibrium. Some patients turn the fear of recurrence into motivation to live better in the present. Some people might say, we don't know I don't know what's gonna happen in the future, but I don't think I want to put things off. I want to do um, things that I want to do, so I have fewer regrets. So this is kind of like a scheme of how most people perceive or have that fear or anxiety come up. So usually there's like a trigger. So sometimes triggers can be certain taste or smell, anniversaries, day of diagnosis, last day of chemo. Media, like watching a movie with a young cancer patient, bodily sensations. So common symptoms that people without cancer have, but because of the experience you have, that will trigger something, a thought, a fear, and cause a physical reaction, which would be like the anxious thoughts, the cycling, the elevated heart rate, etc. Um, so how can we manage some of those fears? So again, the fear is not probably not gonna be gone or go away, but and it could be an automatic thought too, right? Like a trigger happens and that's the automatic thought. And one thought in therapy is cognitive behavioral therapy is like when you have a thought, you need to learn to challenge it. Is this true, etc. I find that talking to someone really helps. And this could be a friend or family member that can listen to you without judgment. And maybe this is the case where a therapist would be very helpful. Because they're not a friend or family member, they know how to kind of listen without judgment, and you can spend like the whole hour with them talking about this issue, working on coping strategies. And I do understand that therapy is an out-of-pocket cost, unless you have insurance benefits that cover some of that. At the Odette Cancer Center, we do have six sessions that are covered with our psychologist. But for therapy as well, it's a trial and error because uh, you need to kind of sync up with the therapist, like as well. Like one therapist may not resonate with you, but another would. So that's also a trial and error. Focusing on what you can control is very important because a lot of that fear is because you feel like you've lost control. Things are happening, and you can't change anything. Some anxiety reducing techniques. I have affirmations, box breathing, distraction, progressive muscle relaxation. And these are all things you can learn, when you're not feeling anxious, so that when the thoughts do come up, you know exactly what you need to do. And on Wellspring, there is a Be Well talk on navigating anxiety and fear of recurrence during cancer. So maybe give that a watch as well. Um, oh, and then just talking about the anxiety reducing techniques, that's also a trial and error because you need to find what works for you, your body, and your mind. Like for example, some people say like yoga really helps me, but for some other people, it can produce more anxious. They might feel more anxious just sitting there. So you just need to find something that works for you. Um, so I'm gonna take some time to read these phrases because I feel like, if these phrases are, on your lock screen, if you tend to be someone who's very anxious, have it posted on the mirror in your washroom to remind you. This might help calm or challenge some of those scary thoughts. Um, so I'm just gonna read it out now so that you can hear it. Right now, I am healthy and living in the present. I am taking care of my body and mind one day at a time. I've already been through so much and proven my strength. Not every ache or pain means something is wrong. I trust my body and my healthcare team. It's okay to have these fears. They don't define my reality. It's natural to feel afraid, but I won't let fear take over my present. I've had clear checkups so far, and I'll face any challenges if they come. Worrying does not change the future. I am focusing on living fully today. I am more than my cancer experience. My body is healing, and I am moving forward. I trust myself to handle whatever comes. And lastly, just a reminder that it's okay if you're struggling. That's normal. There will be ups and downs. It's a marathon, not a sprint. And it's even hard for normal people to do some of these things. So just remember to take care of yourself. And with that, I'll conclude my part of the session.
Perfect. Thank you, Dr. Al-Khaifi. It looks like you're all back and good to go.
Yeah, so hi everyone. Sorry about that. So thank you, Sandy, for all your practical tips. This is really helpful for breast cancer patients. In my part, I'll be talking about mainly menopausal symptoms, specifically vasomotor symptoms, as well as sexual dysfunctions. But I'm happy to answer all of your questions about any long-term physical or psychological side effects from cancer treatment. As you know, I am running the breast cancer survivorship program at Sunnybrook. I just wanted to let you know that I don't have any conflict of interest to disclose today, apart from me being very passionate about this topic. So let's dive right in. I'll be talking about mainly vasomotor symptoms, which is one of the main side effects from cancer treatment. When we talk about vasomotor symptoms, we mean mainly hot flashes as well as night sweats, which are very common as a side effect of treatment. Patients can also experience other symptoms, including sleep issues, mood issues, as well as cognition. It's very common. Almost 95% of perimenopausal women can experience these symptoms as a result of cancer treatment, including endocrine therapy, which is basically anti-hormonal therapies, for example, tamoxifen, aromatase inhibitors, including anastrozole, latrozole, as well as exemestane. Also can be a side effect of ovarian function suppression, which is, we have two medication, which is Zoladex and Leparon, as well as chemotherapy, because chemotherapy can also affect the ovaries and lead to reduce the function of the ovaries, and that can lead to suppress the estrogen levels. And we know that hot flashes, night sweats, and all of these menopausal symptoms can impact quality of life. And some women, including like younger women with breast cancer, just decide that they wanted to stop all these medications altogether because of the severity of these symptoms. We do expect that these symptoms are more intense and severe for younger women compared to someone who turned to menopause naturally. So symptoms due to induced menopause because of all of these medications can be more intense compared to like regular or normal population. So that's why it's very important to treat it, because we don't want women to discontinue their treatment because of the severity of these symptoms, because we know that if we stop the medication, that there's a chance that it increase the chance of the cancer to come back. In terms of treatment, I would say it all depends on your preference, what really fit best for you, and also depends on the severity of the symptoms. So, for example, if you have mild symptoms, probably lifestyle modification can be sufficient to consider. But if you have severe symptoms, so probably you need at least one or two approaches. Let's talk first about lifestyle modification. This includes like cooling techniques, for example, like dressing in layers or using like electrical fan. Other thing that you can try is weight loss, and the recommendation is more than 10% of your basic weight. I know that, as Sandy mentioned, that losing weight is also another issue, and it's hard to lose weight because of all of this endocrine therapy that slow your metabolism. The other thing that you can try is avoiding triggers. For example, alcohol, caffeine, spicy food, hot foods, and liquid. So all of these are what we call like lifestyle modification, but we don't have sufficient evidence, but something that you can try specifically if you want to avoid medications or if your symptoms are severe. So this is what we call like conservative management. In terms of other things that you can try, we do have evidence for mild body techniques, for example, cognitive behavior therapy. And as you can see, this is the levels of evidence here. So for cognitive behavior therapy, it's level A, level 1, meaning that we do have high quality evidence to support cognitive behavior therapy. Again, you can do it individually, and I'll show you how. And the other thing, we can do it like with a therapist or with a group therapy. This is also effective, and this is mainly for women who do have severe symptoms, but in the same time, they don't want to try, for example, medications. And I know a lot of my patients, this is wanted to avoid medications because of all side effects, plus they are already on many medications to start with. The other thing that they can try is also clinical hypnosis, but this is all, you can try it with a therapist. But we do have a good evidence for cognitive behavior therapy. The other thing that you can try, basically medications, which you can discuss with your oncologist or with your like family doctor. The main medications are what we call SSRI or SNRI, which is basically an antidepressant that also can be used to help you with hot flashes. I will talk about this medication in a minute. The other medication is gabapentin, which is also very effective. So these two medications, the SSRI, SNRI, as well as gabapentin, we do have like the most evidence. There's also other medications, including like pregabalin, clonidine, and oxybutynin. All of these medications, they do have more side effects, and they are not as effective. There's also a new medication called Veoza. It's just, I think, a few months ago or a year ago. It's FDA approved. It's very effective. I'm not sure if it's still in the Canadian markets, but till recently it's not. It's mainly in the US market, but we know that it's very effective. We do have level 1 evidence. Let's talk about some of these techniques into more details. We do have some evidence for yoga. However, the most recent studies show it is not as effective, but some of my patients, they found it really effective. So in terms of the recommendation, you can try 90 minutes weekly class for 10 weeks, and as well as home daily practices. This is kind of the recommendation, and that hopefully will reduce hot flashes, like 6 to 5 hot flashes per day. Again, we don't have a lot of evidence, but this is something that you can try, especially if you don't want to try any medications. The other thing, as I mentioned, weight loss, but the recommendation is at least 10% from the baseline. This is the book that I was talking about. So again, as I mentioned, cognitive behavior therapy is something that you may consider. We do have level 1 evidence. If you cannot afford doing this with a group therapy or with an individual therapy, you can actually purchase this book. It's in Amazon, called the Cognitive Behavior Workbook for Menopause. Is less than $30. And so this is something you can consider. And I actually recommend it for a few of my patients, and they find it helpful. In terms of medications, I do believe that many of my patients are on these medications for hot flashes. As I mentioned, especially for younger women, they do have mostly like mild to moderate symptoms, and lifestyle modification alone cannot solve that problem. So adding a medication, for example, SSRI, as I mentioned, SNRI, can be beneficial. The most used medication is venlafaxine, which is basically Effexor. We usually start with a lower dose, 37 milligram, and then we increase the dose accordingly. But also antidepressant, they can help, as I mentioned, with hot flashes, but also can also help with mood. So if you have both hot flashes, mood issues, probably Effexor can be a good option. Again, all of these medications, they do have side effects. So probably you need to discuss with your doctor about that. The second also medication, which is also very effective given based on evidence, is gabapentin. We usually start with a lower dose, 300 milligram, but we can increase the dose up to like 900, even 1200 milligram. It's very effective. Gabapentin can be used for hot flashes, can be used for anxiety, for sleep, as well as pain. I know many of my patients are on gabapentin, but they are in the lower dose, for example, 100 or 300, which is not necessarily enough. So as you increase the dose, you may have better results. But again, there are more side effects with it, especially like being dizzy and drowsy. So see what would be the right dose for you. As I mentioned before, there's a new medication called Veozah, which is approved. It's approved, the FDA approved. It's very effective based on current data, and it's like effective, like almost like 60 to 70%. This is something that you can also consider or talk to your doctor. But I would say the first thing to start is, if you wanted to consider medication, is SSRI, SNRI, as well as gabapentin, and then you may consider other options. Unfortunately, there are some patients, even after using everything, they still have these symptoms. And the thing with hot flashes, night sweat, they can disturb like quality of your sleep. So that's why it's very important to control it, because if you are not sleeping well, then you're more tired, you're not focused, and that can also impact your mood. So it can really affect quality of life, especially if you have severe symptoms. This is also another approach you may consider, which is called satellite ganglion block. It's actually used for pain treatment, specifically for migraine. I honestly just referred one or two of my patients because they tried everything and nothing is working and they have severe symptoms. In the GTA, we do have a few locations that we can refer patient to, but this is something you may also discuss with your doctor if you tried everything and nothing is working. Again, this is not also, we don't have a lot of evidence for it, but it's something you can try or you can talk to your doctor about. Just to summarize, for vasomotor symptoms is extremely common because most of these, as you know, like younger women, they have like induced menopause because of all cancer treatment. In terms of treatment approaches, as I mentioned, there's lifestyle modification, there's mindfulness, or there's the mind-body techniques like cognitive behavior therapy, and there are also some medications that you can consider. Because I do really think that it's important to treat these symptoms because, again, it's affecting your quality of life. You're not feeling well, you're not sleeping well. So if you have it, might as well just discuss treatment options with your doctor. Let's move now and talk about sexual dysfunction. It's extremely common. Like based on some of the recent study, they showed that 70% of breast cancer patients may experience sexual health dysfunction. The main common symptoms is vaginal dryness, again, because of cancer treatment. There's also vaginal pain and loss of libido. There's also a study showed that sexual dysfunction increased 3.5-fold among breast cancer patients compared to women with other forms of cancer. So if you have issues related to sexual health, you are not alone. Like I performed at least a few studies in my clinic, in my program, and this is one of the most common reported side effects. Is not only younger women, like women in their 50s, 60s, they do have issues related to sexual health. Again, when it comes to sexual health or sexual dysfunction, there are many factors come into play. It's like the side effects of medication, like as we just discussed, in early menopause, psychological issues, being tired, physical symptoms too, like having pain on your chest wall or elsewhere. That all can affect your sexual desire and sexual function in general. Also, some issues related to self-image, like self-image, including not only like having, for example, like issues related to the surgery, but also sometimes like hair loss or like having lymphedema or other physical changes. Also, age is an issue, and relationship also issues. So there are many factors come into play when we talk about sexual health. However, I always ask my patient, the best thing to do is to deal first with the physical symptoms. And honestly, like sexual health is still overlooked in our like medical world, especially like in oncology. We need more to advocate for to deal with sexual health issues related to related to survivorship. I would recommend all patients to start this conversation early with yourself, with your partner, and also with your oncologist. Probably this is not the first thing to bring like during your like the first few weeks or the few months of diagnosis, but the sooner you bring this topic to your oncologist, the better. Sometimes I see patients after 5 years of being sexually inactive because of their cancer treatment. So I would recommend from here, just talk to your doctor early, within like the first few months after treatment. If you have any vaginal dryness or anything, just talk to your doctor. If your doctor is not comfortable like treating these issues, then ask him to refer you to to a specialist. Let's talk now about vaginal dryness, which is one of the most common symptoms, but it's also treatable. Like we can treat it because we know that vaginal dryness can also cause pain. Again, the issue is because of low estrogen. Low estrogen means less lubrication, means vaginal pain, as well as atrophy, and that also can increase the risk of infection, including UTI. In terms of treatment, I would say the first thing is vaginal moisturizers as well as lubricant. Like use vaginal moisturizers like routinely, like 3-4 times per week. And there are many formulations. There are water-based, silicone-based, as well as oil-based. See what is the best form for you, and just try it and do it like routinely. I would say, I always tell my patient, the way you take care of your face doing moisturizers every day, you just also take care of your vagina, because we wanted to avoid like dryness. And this is the most important thing, to put it in your routine. So moisturizers is very important. The second thing is lubricants, and you can use lubricants. It's mainly the lubricants is to use it before sexual intercourse, and that to help with lubrication. Also, that will help also to reduce pain as well as dryness. Other thing you can use is hyaluronic acid gel. Again, it's non-hormonal. That's something that you can try like 3 times per week and can help with dryness. So again, as I mentioned, the first thing is start using moisturizers as well as lubricants. Let's talk now about topical estrogen, because this topic comes all the time. Because still there are hesitancy to use topical estrogen. Technically speaking, systemic estrogen, it's an absolute contraindication for all breast cancer survivors. However, topical estrogen, we know that the absorption is minimal, so that's why most studies showed does not really increase the risk of recurrence. However, we still recommend patients to start first with non-hormonal options, which is the moisturizer, as well as lubricant, and then may consider like the topical estrogen. Now we have more and more studies showed that topical estrogen, there's no association between topical estrogen and increased risk of cancer recurrence. And this is kind of one of the biggest study that showed that, as you can see, that there's no increased risk of breast cancer recurrence. I personally prescribe it to my patients, especially if they tried all like other options, including non-hormonal options, and they do have severe symptoms, then it's okay to use topical estrogen, knowing that the absorption is minimum. There are many forms, including the cream, and there's also the inserts. And whatever, like for me, I prefer doing the I prefer prescribing the cream because the cream is from the outside and inside, but it all depends on the patient preference. We can consider either the cream or the inserts. There's also some evidence, but very limited, for laser therapy. It can also help with the vaginal wall, as well as like the atrophy and the vaginal dryness. In terms, and again, it's not funded, it's not covered. So, and it's pretty expensive. It's like it's like 3 to 4 sessions every month. But studies showed that it can be very effective, especially for the short term. We don't have a lot of data in terms of like long-term benefits. But that's something that you can consider. Let's talk now about painful sex, which is, again, is very common, and especially women who do have physical symptoms. Like if you have vaginal dryness and you have atrophy, that for sure can lead to painful sex. So the first step is to treat the dryness. The other reasons why you might have vaginal pain or like pain during sex is discoordination of the muscles. That's why probably pelvic physiotherapy can be effective. Other things you can try is vaginal dilators as well as sex therapy. Let's talk about okay. So let's start. These are the vaginal dilators. They come in different colors, different sizes. But I always ask my patient to start with the smallest size. So vaginal dilators can be used mainly for like to help with painful sex, as well as to help with the flexibility of the vaginal tissue. How to use it is find a private and comfortable space, get into a comfortable position, apply a water-based lubricant, or even you can just use it like coconut oil. Select the proper sized dilators. I would always recommend you start with the smallest size, and then insert the dilator for 15 minutes in and out a few times per week. The idea is using the dilators will work by progressively stretching and desensitizing the pain and the vaginal and helping the vaginal tissues. At some point, you can also introduce your partner, and this is mainly to strengthen to strengthen your muscles as well as to help with the pain. Other things you can try, which is we do have a lot of evidence for it, is pelvic physiotherapy. Again, it's not covered, but there's something that you can consider. Like a lot of my patients, I really get a good feedback if they from my patients, those who considered or been seeing pelvic physiotherapy therapists. In terms of the pelvic physiotherapy, it's more than just Kegel exercises. Usually the pelvic physiotherapists help you to how to coordinate your pelvic floor muscles, also help you how to use the dilator, and provide you with a lot of information. For the most part, we know that we do have a lot of evidence for pelvic physiotherapy, especially if you have pain during sex. Let's talk now briefly about low sex drive. Again, low sex drive is very common. And it's not surprising because cancer patients, they go through a lot. So when it comes to sex drive, there's many factors. The psychological factors, the physical symptoms, the pain, the dryness. So there's many issues when it comes to low sex drive. That's why the treatment is not as simple. It's a little bit more complex, but it depends on the cause to start with. But again, treating the physical symptoms would be kind of the first step. Considering pelvic physiotherapists, also sex therapists will be another way to do it. And I know many of my patients also considered sex therapy and that was helpful. So again, seek help, like ask your doctor or discuss with your doctor these issues, and try different approaches, and find people who can help you with that, like whether it's a therapist, a physiotherapist, or a sex therapist, or also your medical team. In terms of medications, we don't have many options. However, for the general population, we do have two options, which is Velisi as well as Adi. There are also more options, like more oral medications. In terms of Adi, we do have a recent study that was published in 2023, showed that it is effective for breast cancer patients as well as it's safe. However, the number of patients that were included in that study were very small. It was like 37, I believe. So we are hopeful that there are more studies will be published, and hopefully we'll be using Adi, which is pretty effective. It can increase sex drive between like 50 to 70%. Other medication which can be prescribed is Wellbutrin. It's an antidepressant, but also can be helpful to improve sex drive. It's not as efficacious. I would say somewhere between 30 to 50%. I find myself better results with younger women, but again, it's something that you can try, but it's not as effective. Transdermal testosterone is not recommended. Like, we don't have safety data. In general, we don't have many options in terms of like medication to improve sex drive. But I am very helpful that there were more study to at least approve, or more study to tell us more about the safety of Adi and Velisi, because these medications are pretty effective. Other thing that you can try, as I mentioned, Wellbutrin, not as effective, but something that you can try. For me, I have mixed results with my patients. Some find it really helpful, some not. So you can have a discussion with your doctor. So this is kind of the summary of things that we can try sexual health. But I think the key is to start conversation with your oncologist pretty early. Find people who can help you, like therapists, pelvic physiotherapists, sex therapists. Bottom line, just use your moisturizers as well as lubricants if you have vaginal dryness, and discuss if you can try topical estrogen. Laser therapy, I think it's not as affordable, but that's something you can try. So these are like some practical, I would say, tips and some options that you may consider to treat some of these symptoms. I know like there are many symptoms and long-term physical and psychological side effects, but I'm happy to answer any of your questions later on. I'm also like very active in social media, especially my Instagram, and I post a lot of information about like breast cancer as well as menopausal symptoms and sexual health. And I'm happy to answer any of your questions later. So Michelle, she's one of our patients at the PYNK program, and I'll let her introduce herself and probably share her experience. And we're so lucky to have her today to share her experience with us. Thank you.
Hi, everyone. You'll have to bear with me. I tested positive for COVID this morning. So hopefully I don't have any coughing fits. But I'm Michelle. I'm located in Burlington, Ontario. I was 38 years old when I was diagnosed with triple-negative breast cancer, stage 2B, one tumor at the 10 to 12 o'clock position above my nipple of my left breast, with no lymph node involvement and no genetic mutations in October of 2023. I'm saying this as though I am far removed from this diagnosis, but I'm still in the thick of managing everything that has come with what has happened to me and what the future might bring. Cancer has impacted every single part of my life. However, I refuse to let it define me going forward. It's, it's complex. I'm stronger, but I'm more frail. I'm compassionate, but desperately still in need of compassion. I am healed, but still broken. Cancer is not something that we can just turn off when we're done active treatment. I struggle with pain, fatigue, neuropathy, lymphedema, hormonal challenges, loss of my sex drive, and that kind of just skims the surface of my experience. Every phase of cancer comes with its own hardships. I think back to my initial diagnosis phase, it came with debilitating anxiety for me. The waiting and unknown with no plan was excruciating. It took almost 3 months of scans and biopsies for me to get my final diagnosis. And in that time, it was very difficult to cope. If I'm being completely honest, I'm not really sure how I got through that phase. It was a lot of trusting in the medical system and relying on some of my supports. It was complex. Due to being triple negative and the size of the tumor, I was given the Keynote 522 protocol. So this consisted of neoadjuvant chemotherapy and immunotherapy for 16 weeks, followed by surgery, then radiation, and finally nine more doses of immunotherapy. There were many factors that I took into consideration with the surgery that I chose. A lumpectomy with an oncoplastic lift reduction, along with the axillary dissection of my left side, was my final decision. They removed only 3 lymph nodes, but I'm one of the quote unquote lucky ones that has ended up with lymphedema. I completed 21 doses of radiation in August of 2024, and I'm currently in the final doses of immunotherapy with 5 more to go. So I receive those every 3 weeks. So my anticipated active treatment ending is January 29th of next year. Due to how aggressive triple negative is being with a grade 3 tumor, along with the tumor having tripled in size from the time I found it and my first scan to the final scan before I started treatment, I decided that I did not want to take the time to undergo fertility saving procedures. I also have adenomyosis, which is similar to endometriosis, but it's the uterine lining growing within the muscle, and fibroids. So I had been told in the year before that if I wanted to have a baby, that I needed to attempt to do that in the next 3 years before I turned 40. I was told I could possibly have trouble conceiving naturally due to these conditions. And so I decided that fertility saving wasn't my thing. So I struggled with this decision. I grieved the loss of this possibility. I still get sad at times when I think about it. However, I have 4 nieces that I absolutely adore. I'll be the best damn aunt who spoils them absolutely rotten. I also have other options like fostering or adoption should my partner and I choose those paths. We're not in a place right now to do that based on me still being in quote unquote active treatment. But that's something that has weighed heavily on my process. In the 2 years leading up to cancer, entering the picture, I was the most physically active I've been in my 30s. I was hiking the Bruce Trail from Niagara Falls to Burlington and playing recreational, intermediate league competitive volleyball. Because of this, once I started chemo, I wanted to move my body. I started to research all the programs and supports that were suggested to me by my team. Wellspring stood out to me from the very beginning. I was experiencing a lot of anxiety and being stuck in fear-based brain during my chemotherapy regimen. One thing I didn't mention, I am a therapist, so I'm a psychotherapist. And because of that, I knew I needed to manage this head on if I wanted to be able to manage everything in the future and be fit to return to my job. I was incredibly fearful that the treatment protocol wouldn't work or that I would have recurrence within the first year of treatment. I had a lot of thoughts of, was this even, am I putting myself through all of this for nothing? I still have some of those fears and try to manage them with an assortment of coping strategies. And I maintain some gratitude in terms of every day is worth it. Throughout chemotherapy, I completed Wellsprings at the time 20-week exercise program. A lot of people thought I was nuts because I did it during chemo, but it saved me. It helped me cope by moving my body throughout chemo. It connected me with some amazing people who I have kept in touch with. And with that connection, I then completed an 8-week art therapy group, an 8-week breast cancer support group, and a 4-week music therapy group throughout that 8 months of chemo and immunotherapy. I have made some amazing connections to an assortment of people, both with my diagnosis and with other cancers. For me, being around others that understand what I was going through while also respecting my compromised immune system was key. Recovery from surgery was rough. I had never had surgery before. I am grateful to share that I had a complete pathologic response to chemo and immunotherapy. It has left me struggling with whether or not I had cancer versus I have cancer. I am still in active treatment. I still don't know how to talk about it. And that comes with a lot of nuance, because there is a lot of, like what Sandy said, of people being like, well, you had cancer, but I'm still in the thick of it. And I feel like I still will be in the thick of it for a while. I had a pressure sore from the incision on the underside of my right breast that did not close. I couldn't drive for close to 6 weeks because of it. That left me being back to isolated and relying on others, kind of like when I was in the thick of chemo. And this was through the summer when the vast majority of Wellsprings programs were on hiatus. It was hard. I relied heavily on my family and friends' support through this time. I also struggled with adapting to my new body. I had never had surgery, like I said, and although at times I had contemplated breast reduction surgery, I had never gone further than that. I struggled a lot. I cried looking down at my chest. I went from being an E or F cup to probably a C or double D. I haven't been this size since my teens and early 20s. So that's been a big adjustment. Part of my identity has always been somebody with bigger breasts. I cried a lot when I looked down because now I can see my belly and how big it is and has gotten. My body has changed and I'm still coping with this. I've gained 15 pounds since completing radiation. This has been really hard. I don't always feel comfortable in my body, but I offer myself grace and some self-compassion when I notice this. I had trouble with my shoulder and range of motion for radiation, but I made it through. My skin is still discolored. My areola is smaller compared to my right. I'm numb in the underside of my left arm and armpit from surgery. Like I said, I've developed lymphedema in my left arm, chest, neck. My physiotherapist also says I have a lazy lymphatic system. So I tend to retain water really easily, retain fluids. So we're working on that. Lymphedema is a tricky beast that doesn't affect everyone. And it doesn't affect everyone right away. In some ways, I was lucky that it affected me right away because I have the time right now, being off work still, to tackle and get all of this under control. I'm getting a compression sleeve to help manage it alongside physio and manual lymphatic drainage. My goal is to return to playing volleyball recreationally. I don't think at this time, being realistic with myself, that the competitive piece will be there, and that's okay. I'm participating in an exercise study through McMaster University because not only do I want all the support and resources I can get, I also need it to get back into moving my body. So with my return to being on immunotherapy, I am managing leg and joint pain, radiation-related fatigue still, along with immunotherapy causing fatigue. I struggle to move my body in the ways that I want to, but I do my best to offer myself some grace and compassion. Those are two of the biggest things. I attended a Pink Pearl Canada retreat 2 weeks ago and connected with other young women who have had cancer. I'm also part of the PYNK program at Jervinsky and Sunnybrook. I attended Hamilton's Life After Breast Cancer conference yesterday. I'm doing everything that I can to heal. My biggest thing is being vulnerable with others and sharing my story, getting validation from other women who have had similar experiences to my own. Sometimes it just helps to be able to talk about it and to acknowledge that this is hard, even if there's no immediate solution. Knowing that we're not alone makes a big difference. Everything we experience is a part of this storm, and giving yourself permission to respond in your own way and in your own time. Cancer has changed my life permanently, even if every cancer cell is destroyed and gone. My GP compared cancer to going through a hurricane, and the damage varies and it takes a long time to rebuild and heal. And so offering ourselves some grace and compassion, and knowing that, for me, I have accessed every single support I can possibly. Some have fit better than others, and some I've just said, this isn't the right thing for me. Each of us will have a different way of doing things, and what works for one person might not always work for someone else. And it's being gentle with ourselves around that. Finding strength in different things as I transition to survivorship. Tom McDonald's lyrics in his song called Cancer speak really deeply to me. So I'm going to share that with you. You don't know how to be brave till you choose to fight when you're afraid. And you can't experience strength till you've struggled to carry the weight. And you won't know why you have faith till you look the devil in his face. And you don't know what you can take till you realize you didn't break. So be gentle with yourself as you weather the after effects of the storms that we've all just been through. Reach out to supports in your own way, in your own time. And I hope my sharing my story has helped in terms of being aware of different things and kind of building on what Sandy and Dr. Al-Khaifi have shared.